Well, it's a pleasure to be here this morning and to tell you about the leadership of transgender women in the IPREX study. I'll be presenting some new information about women's experience in IPREX. This is being prepared for publication under the leadership of Maddie Deutsch and others at the Center for Excellence at UCSF. So we're very proud to be sharing this information with you for the first time in the world here at the Trans Summit. So the IPREX study was a clinical trial of Truvada pre-exposure prophylaxis. It enrolled and followed participants between 2007 and 2010 and published its results showing safety and efficacy of PrEP for men who have sex with men and transgender women in November of 2010. And as you can imagine, we had a big celebration for that AIDS Day, imagining that this could impact people's lives and change the course of the HIV epidemic. I think that over the following 4.5 years, we've really learned a lot about how PrEP might work, but we've also learned to appreciate that the leadership of people in each of their communities and in their own lives is absolutely essential for turning possibility into reality. There was a successful alliance between trans women and the IPREX study. And I wanted to just highlight several events that really, I think, helped us and learn from each other. First of all, our study was sponsored by the National Institutes of Health, and the title of the study was Chemoprophylaxis for HIV Prevention in Men, and we very quickly learned that this was offensive and non-inclusive, and so really at the behest and the insistence of trans women advocates, especially in Sao Paulo and Lima, Peru, Sao Paulo, Brazil, and Lima, Peru, the name of the study got changed to Chemoprophylaxis for HIV Prevention in Men and Transgender Women. And so we're very proud of having been able to move the U.S. government and the NIH in this regard. But at a more local level, we had several sites who needed their study participants to be able to present government-issued IDs in order to participate in the study, and this can be a problem for trans populations. There was leadership by the study site in Ecuador, for example, to allow issuance of government IDs based on current gender. They did this to facilitate the participation of transgender women in our study, but they also did it because it was the right thing to do. The study just created an opportunity for this advocacy to take place. IPREX investigators in Brazil demanded that social IDs be accepted when accessing government health services. And so again, this was a change that was made because we wanted to welcome transgender women into our studies, but in fact, this change in policy changed how trans women access all health care in Brazil. They can now present social IDs instead of their government IDs. Trans women were also on the cabs and key leaders in recruitment at all study sites, and they played a major role in communications, and the narratives of trans women were highlighted in both of the major movies to come out of IPREX that are still on the web. One is called Voices of Hope, the movie made before we had the results of IPREX, and Voices of Choice, the movie that recapitulated our findings. So trans were very much involved in IPREX, and I am very sorry that this has been obscured in many of our publications, and working with the UCSF Center of Excellence, we're trying to change that and improve that. And this is information that is being written up under the leadership of Maddie Deutsch, and this describes in a more full way the trans experience in IPREX. I think most people know about the 29 women who were in IPREX. Mind you, everyone was born with an assigned sex of male, but there were 29 women who enrolled, or 1% of the cohort. But in addition, we had we had 296 people who identified as transgender women, and another 14 who did not identify as trans, but they were using feminizing hormones. So overall, 14% of the cohort was trans-identified or women-identified or using feminizing hormones in a very active way. And for sure, IPREX trans women are not men who have sex with men. There are multiple differences between the trans women in our study and the men who have sex with men, including the trans women having overall less schooling, less years of schooling, more sexual partners, more condomless receptive anal intercourse, which is the major risk factor for HIV acquisition for both trans and MSM. In this particular study, and trans women were more likely to be participating in transactional sex. This is just a few of the differences. There were multiple differences in living situations, partnering across the board. So trans women were very different from men who have sex with men. One thing that was not different was how well PrEP worked when it was present in the body. And so this is a graph that shows on the x-axis the level of the PrEP drug, tenofovir diphosphate, in the blood of trans women in red and MSM in blue. And on the y-axis, we see the reduction in HIV incidence. And so lower numbers associated with a greater reduction in HIV incidence. And you can see that for both trans women and MSM, the drug works when it's present in the body, and to a similar degree. But the difference was that trans women used PrEP differently and overall less frequently than MSM in IPREX. And this is a graph that I think is complicated, but I want you to take home the notion that use of PrEP and adherence to PrEP is complex. It requires that people use it when they need it, and they can stop using it when they no longer need it. And so we have to keep track of, or individuals who are PrEP users have to keep track of how best to use PrEP in their own lives. So it's different in that way from HIV treatment. HIV infection, when present, is ever present, but HIV exposure is episodic. And so what we need for PrEP to have an impact on our communities and turn the course of the HIV epidemic, what we need is for individuals in very different social circumstances to use PrEP when it's needed the most. And here we did see differences between MSM and transgender women. MSM on the left, transgender women on the right. Interestingly, transgender men were more likely to use PrEP every day than trans women, but trans women were more likely to try it and try to use it at certain times. However, MSM were more likely to use it when they were having more sexual exposure to HIV, whereas trans women were less likely to use PrEP when they were having more sexual exposure to HIV. And for these reasons, the overall impact of PrEP in trans women was less, tended to be less than it was for men. But it was all about strategic dosing. So I think that one of our take-home messages from PrEP, and this really was inspired by the experience of trans women in IPREX, was that how PrEP happens, how it's promoted in our communities, how it is used by individuals makes the difference. It makes the difference in whether PrEP stops HIV transmission or whether it's just another drug taken along the way. So it makes the difference particularly for women, including trans women. And so how PrEP happens with respect to access, agency, inclusion, and community makes all the difference. And I want to highlight, using this poster from Planned Parenthood, which is really oriented towards cisgendered women, I wanted to highlight how we're seeing substantial social similarities between the situation of cisgendered women and transgender women. And I am thrilled to hear some people talk about we are all women, and I want to include myself in that. So I wanted to end by talking about stigma, because I think that when we talk about the importance of agency, it really is about stigma. How do we mitigate stigma? And one thing that I think we can do every single day, and each one of us can do every single day, is to be more mindful of the words that we are using. And my fascination with words comes in part from inspiration from Nelson Mandela, former president of South Africa. And he said at Durban that it is never my custom to use words lightly. If 27 years in prison have done anything to us, it was to use the silence of solitude to make us understand how precious words are and how real speech is in its impact upon the way people live or die. And I think in HIV prevention, we need to be more mindful of our use of words. We need a new sexual health lexicon. Too often in HIV prevention, we use stigmatizing words. And although our intentions are good, these words divide us into an us and a them. And so even if our intentions are good, it's still stigmatizing, it's still othering. So what do we say in HIV prevention? We often talk about them, their needs, high-risk people, risk behavior, targeting them for interventions. We talk about discordant couples. We talk about recommendations, and we talk about adherence. All of these words imply an us, a knowing us, a generous us, and a them who are needy and in some ways weak. I think we need a new lexicon that is inclusive. We need to talk about us, our desires for human connection and for sex. Instead of high-risk people, I think we can talk about popular and affectionate people. Risk behavior can become intimate sex. Instead of targeting, we can talk about mobilizing. Instead of discordant couples, we can talk about people being in love and the power of that and the risks of that. We can talk about choice instead of recommendations, and we can talk about use instead of adherence to medical indications. So we need a new lexicon. So I wanted to thank the UCSF Transgender Center of Excellence, especially Joanne Keatley, Jay Sevelius, Maddie Deutsch, and they are assisting me in my transition toward cultural competence with regard to gender identities and gender health. It's a long road, and I'm only part the way there, but I thank you for helping. So I wanted to end with a movie about hope.